let's just make sure.
I see the red live button, so I think we're good.
Awesome. Yes, we are. Yes, we are. Hi, everyone. This is the voice and the face of Dr. Funke Afolabi Brown, the founder of Restful Sleep MD and the Restful Sleep Place. And our mission is to help individuals, parents, busy moms, and their children change their relationship with sleep. Because when we do change that relationship, like magic happens. And listen, I'm going to be giving you a sliver of magic today. I have one of my friends. I can actually call her a friend. It's interesting how we meet these phenomenal people on our paths, especially for me personally on my journey towards entrepreneurship. And you just connect so quickly. And then they become these incredible cheerleaders. I'm like, oh my God, thank you. And so I'm so excited to have Kelsey Baker here, who is phenomenal, and you understand why. And we're going to be talking today about all things oral ties. So we're talking lip ties, tongue ties, and really just really sharing so much knowledge. So y'all buckle up. It's going to be very informative. So let's get started. Kelsey, like I said, I will never do it justice as I've tried to introduce you. So could you just tell our people who you are and what it is that you do?
Of course. Thank you so much for having me. I'm really excited to be here. I'm Kelsey Baker. I am a pediatric occupational therapist, lactation counselor, and cranial sacral therapist. I live and work in Philadelphia, and I also help families virtually. So I really specialize in the world of tethered oral tissues, or TOTS, which is part of my business name. So it's not an accident. And I ventured into this world because I learned way too much about this for my daughter, who's now 7. But, as one does, we learn a little too late. And I shouldn't say too late, but like I wish I'd known all of these things when she was an infant. So now I get to, impart what I know on the families that I work with. And it is it's really impactful work, and I'm so grateful to be able to do it because I just had an open house at my new clinic space, and one of the moms that I worked with in the early days of my business, about 3-4 years ago, introduced herself to my mom, who is also there, and she credited me with changing the trajectory of her daughter's life. And that just like, it meant so much to me. And I think it really is true. Also, if you hear that sound, that I'm right by the train in Philly. So that's what that background noise is. But I I really think that we can like steer the ship in a different direction when we're able to help these little ones in the early days. And like we can always make change. It's never too late. I know that from personal experience for myself and my kids, but it's much easier and really magical when you're able to start in the first few days, weeks, months. So that's what I
I'm
really
just
focus on.
I'm having goosebumps right now. So, occupational therapist, and I never knew TOTS was tethered oral ties,
Tissues, yeah.
tissues. Oh my gosh, that is brilliant. Because I
Thank
thought
you.
it was TOTS like toddlers, but then I'm like,
Mhm.
well, you work with infants. Why would it be TOTS? But little kids. But that is so catchy. It is, and I love it. I love all of it. And just that story about the lives we touch, right? So here we are, we show up and we're like, well, I'm doing what I'm good at. But what we're good at is a need, a prayer for someone, right? That then changes the trajectory. And this is the thing that I talk about too, where when we make a child either feed better, sleep better, rest well, become the best versions of themselves, it's not just that child. It's literally a whole generation going, ahead. And also the parents relationships, occupation, the rest life, their wellness, their quality of life. So this is a big deal. So thank you so much for all that you do. Now, I'm sure people are wondering, okay, sleep, oral tissue or tethered oral tissues, and just maybe share to start with some of the kind of cases you see, and then we'll delve into, some of those conditions and things like that and how it can impact kids.
Yeah, of course. So I usually get referrals from lactation consultants and sometimes pediatric dentists. Um, and because there's some level of oral dysfunction and or a suspected tie, whether that's lip, tongue, or cheek ties, we call those buccal ties. And we all have frenum, we all have frenulum, or those little attachments that actually stabilize our muscles. So we all have a frenulum that connects our tongue to the floor of the mouth. Most of us have some level of frenum in our cheeks, and we all have some level of frenum in our lip, upper and lower. So we need those to some degree to stabilize. It's not always a bad thing. They're considered tied when they get in the way of function. So they can really impact breast and bottle feeding. They impact sleep. They can impact just how babies go throughout their day, right? If you're not able to lift your tongue to your palate, it actually impacts how your face grows and how well you're able to breathe and how well you're able to eat. So it impacts all of these things that are big players in our overall health and wellness and how well we can grow.
So, how do people find out that they have these, either, like you mentioned, lip, tongue, or cheek ties? How do they discover that? Is the main symptom difficulties breastfeeding? Maybe tell us a little bit about that.
Great question. So sometimes it's painful breastfeeding. That's a big one that people hear about. And there's pinching, there's rubbing, there's just like really uncomfortable nipple situations that I personally experienced, and I don't want anyone else to have to do that. It's not a good time. And we don't have to martyr ourselves as mothers to go through that and just think that that's normal. So there's a level to that, but there's also excessive gassiness, reflux, colic. Those are all things that go into it. When you don't have a proper seal at your breast or bottle, you're going to intake air. And that is a big player and main contributing factor to reflux. So the babies that are kind of lumped into this colic diagnosis, which is just a symptom, right? It's not a diagnosis. It doesn't give us any reason why they're colicky and upset and uncomfortable. But a lot of times those are the babies that I see. I also get a lot of referrals for head shape concerns or head tilt with torticollis and plagiocephaly. And almost all of those babies that I see also have tethered oral tissues. And it's not necessarily a direct causation, but there's a correlation there, right? If you have tight fascia, which is what those frenum are made of, you're going to have more body restrictions. You're going to be slumped to one side. You're going to be constricted and restricted in many ways. So they all go hand in hand, and feeding as infants and adults and everywhere in between is a full body activity. Like you need to have your body stabilized and comfortable in order to engage in the activity of eating, right? And be able to do that calmly and with coordination and be able to breathe at the same time, and or at least in a coordinated fashion, not exactly at the same time. And all of those things play into how well you sleep. So a lot of times I do see, I'm not treating sleep per se, but I am improving sleep dramatically with the kids that I work with. And then I also see the older kids sometimes and the trickle-on effects of what that looks like, because the babies that maybe got by and were okay, or we didn't know that it was a big deal to, and maybe families thought that their level of spit up and reflux was normal-ish, and they were just like a colicky baby, but they were fine overall, right? And those are okay scenarios. And sometimes those babies turn into the picky eaters, the delayed speech toddlers. Maybe you needed ear tubes for them because they got chronic ear infections, or maybe they had adenoid and tonsil inflammation because they were chronically mouth breathing. And that is just kind of like a domino effect of when we don't address it. And sometimes even when we do, depending on the impact that tie had or the level of function, we still have those trickle-on effects. And then with adults, there's more TMJ, chronic migraine, sleep apnea, disordered breathing, a lot of times orthodontia that doesn't stick, right? If you had braces for 2 or 3 times, or you need to wear your retainer every night, or your teeth shift back right away, that's due to poor tongue posture most of the time. And it usually leads back to a tie, not all the time. I think a lot of people blame ties for many things, and it's not always the tie itself. A lot of times there's more to it than that, with your oral facial structure and your muscle tone and your nervous system and all of those things. So, yeah.
That is incredible. So it sounds like you see infants, but an older child, how would they present that would make you think, oh, this is probably related to, an oral tie?
Give me an age and I'll give you an example.
So maybe like a 4-year-old who's maybe a picky eater, or I don't know, not gaining weight, or I don't, or mouth breathing.
Yeah, so I actually have a 4-year-old on my caseload right now who is a very picky eater. Weight has been a concern. Very narrow palate, very crowded teeth, just baby teeth at this point, obviously, and snores like crazy. Is a very hot sleeper, is drenched in sweat all of the time. And this child presents like they would have a tie, and they do have a posterior tie, but it is more about coordination and strength than the actual restriction in this case. So lots of other things need to happen. And who's to say, if like I had been able to work with this child as a baby, I don't know what that trajectory would have looked like. I would guess that the tongue would be a little stronger and been able to form that palate a little bit better. But at this point, the goal is, with a 4-year-old, it's hard to do a tongue tie release, because unless you're doing another surgery that might look like a tonsil or adenoidectomy, or ear tubes or something like that, then you can pair in a frenectomy at the same time, or frenuloplasty, and do sutures, so you don't have to do wound care. With infants, it's not worth doing the anesthesia. The risk of anesthesia is too great to do that for this procedure, and you can do wound care. So you have this post-op procedure and follow-up care that's really important, so it doesn't reattach. But with older kids, sometimes you can lump it in with that. But this 4-year-old, yeah, lots of open mouth breathing, lots of like fidgety sitting, just, you can also usually tell with just like venous pooling underneath their eyes, and their face is usually longer. So that's all a sign of oral dysfunction and or ties.
That's really good to know. Those are classic, anybody out there, please hear me, of sleep apnea.
Yep.
So especially in a child about 4 years old, and I wanted that age because that's around when the adenoids, the tonsils are big, and then now combine that with oral dysfunction. And it's like chicken or the egg, which came first? I mean, some of these can then predispose you to having larger tonsils, larger adenoids, because of that inflammation, which may occur because they've been chronic mouth breathing, so because of the oral dysfunction. So it is an interesting dynamic, and I think that is why the work you do is so important, and that is why just partnering with sleep experts, ENT, other people, to say, okay, where is this going on, so that we know how to move forward. And I think that it's a great segue to maybe just tell us a little bit about how these restrictions can impact sleep. Like, how does it lead to difficulties breathing during sleep?
Yeah, that's a great question. So especially with the tongue frenum, that's the major player for most of these. Lip ties a little bit, just with getting that lip seal. But what you really need for restful sleep is your vagus nerve to be stimulated and to be in a parasympathetic state, that rest and digest state. So ideally that happens with your tongue elevated and suctioned to your palate, right? That actually pulls down your palate and helps form your face as you're growing. It also keeps your tongue from falling back into your airway and allowing you to breathe more easily when you're asleep. So when we're sleeping, we want to be breathing through our nose, our tongue elevated and suction to our palate, and our lips sealed. What we see a lot is with oral dysfunction and tethered oral tissues is that the tongue is low in the mouth and it kind of gets lost. It doesn't have a home. It doesn't know where to go to that parking spot on the palate. So it falls back as we get tired, right? Everything gets a little softer and looser as we fall asleep, and that tongue goes back and can block off the airway to some degree, and then you have snoring and more disrupted sleep because you're not able to activate your vagus nerve and get into that nice deep sleep. And also you're just not getting an ideal oxygen either because your nose humidifies and filters the air that you're breathing in, whereas your mouth does not. So there's a lot of factors to that.
Great. I love that. And I think this is really important to highlight. And this is part of what we do during an evaluation. If there's a child that has snoring, yes, we do want to examine where could the obstruction be or where could the obstruction be. And in some situations, we have children who, yes, maybe they have ginormous tonsils, which are those tissues at the back of the throat. And you could just see them and you're like, okay, imagine how this looks when the child goes to sleep and the muscles are relaxed, right? You could have, the big adenoid, which is really at the back of the nose that kind of filters any particles, but becomes really big around the age about 2 years old to about 8 years, which is where we really start to see that. So that's another level. The oral cavity and the position of the tongue is such a big deal, which is why when I look, I'm not just looking for the tonsils, I'm looking up and seeing where is the roof. And sometimes you see almost a steeple, which is exactly what you've said, especially for those kids who are older, because they've not really had that nice seal to allow that facial development. So it's almost as if the palate is kind of slowly gone up as their face has gotten longer. And you can imagine when we think about that, like you said, you need that seal, you need that tongue to seal on that hard palate so that when you lay back down, your tongue is just sitting where it should be. But if it has nowhere to sit, it's going to fall to the back of their throat. So you might have a child who has maybe okay sized tonsils, maybe not so big adenoids, but they're still snoring. They might still have sleep apnea. And then we start to say, what else could be going on? And I think that is just really important. Now, my next question would be then what? How with this? Like, take us through maybe an infant and then maybe a slightly older child. So we just kind of get the full breadth of how you help these kids that have oral ties.
Yeah, so usually when an infant comes to me, I do a full body assessment, I observe a feed, I do an oral assessment, and we kind of talk about what things might look like, right? How significant are the challenges right now? How much intervention are we willing to do? And what are our goals? Like, what are we working towards, right? I'm not going to impose a goal of exclusive breastfeeding on you if that's not your goal. I'm not here for my goals. I'm here for your goals. So usually I like to do at least an evaluation and a 1 week follow-up and see where we're at, see how they've responded to some initial strategies, some exercises, some movement play, maybe feeding in a different position, tweaking some things. And then I have a much better idea of kind of the timeline and trajectory that it will take. On average, I see infants a total of 6 sessions, sometimes more, sometimes less, but on average, it's about a 6 to 8 week process, and there's about 6 visits there. If we are planning to have a release, if the anatomy dictates that a frenectomy would be warranted and their tongue is very restricted and it's not just muscular tension, then we will usually use those first 2 visits to prepare for a release. They'll have a release with a preferred provider. In my area, that's a very highly skilled pediatric dentist who does a laser release. And then I help them through the post-op care with wound care, more exercises to get full function through the whole body, because neck mobility is a really big player. You have to have a mobile neck to have a mobile tongue. And I think that's really overlooked, especially in infants, right? We talk about torticollis, which is a tilt of the head, and people, mostly pediatricians, will define it as like a tightening of the sternocleidomastoid. And it's not just that. It is maybe a piece of it, but it's a whole body situation, right? There's almost never isolated tension or torsion in just that singular muscle. It just doesn't happen. So you have to take a full body approach and look at it from a global lens. And I think that's what a lot of providers are missing. And that's why I'm able to have such a strong impact in those early days. So those are my favorite cases, just because it's like, we can make so much change in such a short period of time. The longer we wait, the longer it takes to get to the goal, right? And I usually describe to families that there are chapters to this, because sometimes if that baby has a really high palate and had a really restricted tongue, maybe we hit our initial goal of breastfeeding or, easy bottle feeding or whatever it may be. And I know that there's going to be some other things, right? That palate is still going to be high, and it's not going to come down overnight. It's going to take some work. So that sounds really scary to new parents, and they don't want to be coming to therapy once a week for the next, 6 years. That's not sustainable and not fun and not going to work for anybody. So I kind of prepare them with there's chapters of this. You might want to check in around solids. You might want to check in around their first birthday, maybe around 18 months. Let's make sure we're doing all of the things that we can to keep you on this trajectory. And we might have another chapter of more intensive therapy where I'm seeing you more frequently, or maybe we're just a check-in and I'm saying, hey, keep working on these things. Here's your new little updates, and have a good one. So I kind of call that maintenance. And if I get a baby older, so right now I have an 8-month-old, and they didn't realize there was a tie at play until about 7 months, which is a tricky time to do a release with a very active older baby. You really want to avoid creating too much negative association with any wound care in their mouth. They're introduced to solids at this point. Feeding patterns are pretty well established, whether that be breast or bottle, and they're already going through so much change. You don't want to create this negative power struggle, and that carries on until about 3, 4, 5 years of age. So it's a trickier time, and it's a really case-by-case basis if it makes sense to do a release or continue to do a more conservative approach and work diligently with therapy and oral motor therapy to encourage the tongue to elevate to the palate, lateralize more, decrease tension, increase strength, all of those things. For an older child, depending on the age, sometimes I come at it from a more feeding therapy perspective. And we're working on jaw strength and moving tongue side to side. And it really depends, again, case by case basis, if we are thinking about release at that point or not. Even older still, I personally have a 7 and 10-year-old, and they are both in palatal expansion currently, and will likely both need tongue tie releases after they get through this first round of maxillary expansion. And then one will for sure need mandible expansion, and one is on the fence. So we'll see how much she's grown. But yeah, and that's not my area. I don't do any of those expanders. That is obviously an orthodontist. That is not my realm. My realm in that is to work on the nervous system, continue to work on their tongue movement, awareness of where they're eating, how they're breathing, all those things. And usually if I see a client in that age range, there's other things at play that would warrant seeking services, right? So it would be some sensory concerns or motor planning or reflex integration, some level of asymmetry, and then we'll end up talking about more airway and oral motor and all of those things. So,
yeah. Wow. Wow, there's a whole lot going on there.
Yeah, sorry, that was a whole novel.
No, no, it's powerful, and thank you so much for taking us through that based on the different age groups. It sounds like the fun, easy, let's get it done and move on is like the much younger. But there are things start to get more complicated as they get older. And I think that makes sense because now some of the complications we were trying to avoid by doing it early have set in. So it's managing a lot of that. But it's really helpful to hear what your role then is, even with now helping them navigate that, regardless of the fact that they may need other forms of intervention. So this has been really informative, I would say, even for me. I've met with you and we've talked a little bit about the work you do, but really hearing it from this perspective is has been very, very informative. So where can people find you? Where can that mom who's like, listen, something is going on, or the lactation consultant, or even the orthodont, the pediatric dentist, or the sleep doctor? Where can people
Yeah.
find?
I am most active on Instagram, so I'm Be Well Tots on Instagram. Yep, thank you. It's just the letter B, not BE. Um, so Be Well Tots on Instagram. You can find my website at www.bewelltots.com. I'm Be Well Tots everywhere. So if you search that, you will find me. Yeah.
Wonderful, wonderful. Well, you guys can see why I had to bring her on. I hope you've all left with just some nuggets and, a different perspective around oral ties and how that can impact our breathing, our feeding. We want our kids to be happy, healthy, and to be successful. And the body is not just, it's not, it's kind of like broken into different systems, but everything has to work in order for the body to work, right? So this has been very powerful. Now, if you're out there and you're like, well, my child is having sleep struggles, I'm not sure what it is. I'm not sure if it's sleep apnea, it's snoring, a child that's waking up frequently, or you're even a parent that's struggling with your own sleep, a mom, an individual who wants to get a better sense of how to make this sleep a thing, and you want to practice where you are seen and you are heard, then the Restful Sleep Place is for you. And you can find us on our website. It's therestfulsleepplace.com, or you can call our number. It's 215-607-8297. We see patients in Pennsylvania. Now we have in-person services, and we're actually networked with a few insurances. So if you're wondering if this place is for you, it is for you. It's 215-607-8297. And it's been amazing hanging with you all this day, regardless of when you eventually watch this, whether you're live or you come back to watch this. I hope that until next time, you rest well. Bye, everyone.